We have a special treat for you today. Trish Rivera is here to talk to us about rural health. Since October of 2019, Trish Rivera has served as the East Texas Rural Health Specialist with the State Office of Rural Health, an organization that is dedicated to serving the health needs of rural Texas. The State Office of Rural Health staff work with local healthcare providers, county leaders, and state partners to support access to quality healthcare for rural Texans. The State Office of Rural Health supports rural health providers by providing technical assistance with finance, operations, and quality through a variety of grant workshops, programs, and one-on-one assistance. In addition to working with rural hospitals, Trish manages their Rural Health Facility Capital Improvement Program grant and the Texas Farmers Mental Health Awareness and Suicide Prevention Program. Prior to working in rural health, she spent over 25 years as a social worker in areas of early childhood, substance use, and child welfare, administering home visit programs, managing grants, and participating in community planning networks. Let's all welcome Trish Rivera. And Trish, I'll hand it over to you. Thank you so much for being here.
All right. Thank you, Molly. I appreciate you inviting me to speak to your group today. I know I gave just a brief couple of minutes at one of the council meetings not long ago. And thank you all for welcoming me. I'm happy to share information with you on rural health and also a little bit on our agri-stress helpline, which is a 24/7 crisis line for folks who work in agriculture. So we're going to go ahead and get started. So as Molly had said, my background is as a social worker. So coming into the rural health area is definitely a huge learning curve for me. I feel like 5 years later, I'm still learning a lot. There's always something new. So I'm going to go ahead here and share my screen. All right, can y'all see that? Okay, great, awesome. Thank you. State Office of Rural Health, we have been in a number of different agencies. We've been around for a good while. Our current home is Texas Department of Agriculture in the Trade and Business Development Division. We love being here. It seems like a strange place for rural health. And just let me state too that we are a non-regulatory office. We don't regulate anything in the hospitals. We are there as a supportive service. And so folks do sit up a little straighter sometimes when we walk in the room and tell them where we're from, but then we tell them to relax. We're actually really just here to help. As you know, Texas is a big state. So we have a regional approach to the work that we do. And again, as we said, we provide a lot of supportive services to our hospitals. So our mission is to care for those who care for others. So we're here to support them in lots of different ways. And we'll talk a little bit about that as we move through the presentation. First, I'll give you just a tiny bit of background on the SOAR, our regional approach, our funding. So our core functions are to collect and disseminate information to the hospitals. We provide technical assistance, as Molly said, on finance operations, and quality improvement. And we do a lot of different activities. We put on webinars, trainings, such as a quality improvement boot camp, a chief nursing officer boot camp. We did a 5-part series on trauma-informed care from the emotional perspective and psychological perspective of trauma. We've done things on billing and coding. So we have a really wide range of topics that we touch on with our rural hospitals. They need support in a lot of areas. Our main funding source, and we have several, but our main one is the FLEX program, which comes through a Medicare, a Federal Office of Rural Health policy through HRSA. And that is to fund a lot of the needs for critical access hospitals. A critical access hospital is a hospital that has to be 35 miles from the nearest healthcare facility. They have a little bit different reimbursement rate with Medicare and Medicaid, CMS, what they call CMS, the Center for Medicare and Medicaid Services. And they are licensed for 25 beds or less. And this is where a lot of our finance operations and quality improvement training comes in. However, there are other rural designated hospitals that, if there's no cost to us, can attend our trainings, and we're happy to have them. We want to help as many rural hospitals as we can. So this is our regional approach. My region is over here on the right for East Texas. And then we have 5 other coordinators. We are an office of 9 people. We have our director. We have someone that handles our educational focused grants for student loan reimbursement, and another person that handles a lot of our really important rural health clinic work, which has been kind of a new area for us the last couple of years. Little background on rural health care facilities. We have 90 critical access hospitals. I know it's a little too tiny to see here on this where they all are, but as you can see, the majority is, of course, over in the more heavily populated part of the state. We have 354 rural health clinics and more to come. Um, we do have federally qualified healthcare centers. We, as an office, don't work with them. They get federal funding in a very different way than what we are getting. And then we have our more short-term PPS, which stands for prospective payment, and that is a payment model within the Center for Medicare Services. But we do work with the PPS, the critical access hospitals, the rural health clinics. And then a little over a year ago, this new designation for a rural emergency hospital came out that was designed to keep a small critical access hospital that had a low patient volume of maybe 1 to 2 patients per week or per day. And they didn't want to close the hospital because if they did, they would lose their emergency services and maybe some of the other lab work and imaging services that they do. So those critical access hospitals with that low patient volume were able to choose to change their certification to a rural emergency hospital, which kept then medical care in the community. So we've had 4 hospitals convert. I have one in East Texas in my region that's converted. So I want to talk a little bit about the impact of rural hospital closure. And Molly, I actually sent you a link to a document where some of this info comes from, if you'd like to share it with everybody. Um, we do feel it's really important that you all understand the impact of rural hospital closures on your communities. It's just a huge economic impact. As a matter of fact, we have field reps. We have 10 of them that cover the state. They actually are going on our hospital visits with us now. They themselves are learning about the impact of rural hospital closure because what they do is they work with local folks as a representative of TDA on economic business development in terms of their agriculture. But they also, because the SOAR is within TDA, they can also speak to the impact to those community members on the impact of a rural hospital closure. So obviously, if you lose a hospital, you've got to, travel maybe 45 minutes to an hour to another facility. You face your possible loss of emergency care. It's a huge loss of jobs in a local community. On average, 170 jobs are lost. It's often the largest employer, if not the second or third largest employer in a small community. So people move away, get jobs elsewhere. You're losing sales tax revenue. All those people aren't shopping in the community anymore. People from outside the community that worked at the hospital are no longer coming in to work there. So they're not getting gas at the convenience store or a drink or something else, hitting the grocery store on the way home. You also have a reduction in school enrollment numbers. So that drives down the state payments to your schools. So that also harms your educational services. So lots of harm to local business and also impedes community growth. So say there's a new business or a large employer that wants to come in, move into the community, but there's no health care. They're going to want health care for their employees, especially if they're going to be employing a large number of people. Young families with children also, not having healthcare in a community is a serious consideration for them. So it is a problem if you lose a rural healthcare facility in terms of really growing the community and bringing in more jobs. And so we really want to try and support those. So rural Americans are at greater risk for poorer health outcomes. In the rural areas, you have people who are older, have more chronic diseases. They're mostly Medicare, Medicaid. You also have a low income population that's Medicare as well. I'm sorry, or Medicaid. I always, even though I'm in this world all the time, I still can't get those two straight. So you have people then that don't have private pay insurance from an employer, which the coverage for those and the payment to the hospitals are better. So if the hospitals largest insurance payment is coming from Medicare, Medicaid, which does not generally pay for the full cost of that care. They're always going to be running at a deficit. So, in an area like Austin or Houston or urban area, you have a greater payer mix of people with good healthcare insurance from their employers, and you don't have, and they can balance out what you see in rural areas in terms of just the Medicare, Medicaid payments. So, and also urban areas have more foundations; they have more indigent care dollars to draw from, so that also, you know, adds to the disparity. You have higher rates of smoking, high blood pressure, COPD, diabetes, obesity, heart disease. A lot of these are lifestyle related. Not all of them are. Um, of course, everybody kind of gets something once in a while. It has nothing to do with how they're moving or eating or what they're ingesting. You have low leisure time physical activity. You have a lower seatbelt use, higher rates of poverty, lower levels of health literacy, obviously less access to healthcare, especially if your hospital closes and you're less likely to have health insurance. One of the other issues too is transportation. If somebody doesn't have a vehicle to get to the hospital, perhaps the ambulance can take them, but if they have, if they don't have a car, but there's somebody in the family does, but that car is used to go to work, they're kind of stuck at home. We've actually had hospitals use their ambulance or the local police to take somebody from the hospital after they've been there back home because that person doesn't have transportation. And so that transportation is a burden. And, you see all these ads for Medicare Advantage, which has been really harmful to our rural hospitals. They don't, and they talk about having dental care and transportation and things that you can have access to, vision, but there is no Uber, there's no transportation in rural communities. There's no Lyft. There's most of the times it's a health professional shortage area for um, eye doctors and dentists and mental health services, and sometimes even healthcare itself. So it is really a challenge. A lot of hospitals are educating their patients on choosing their plans for Medicare, whether you choose Medicare Advantage or they don't say choose one or the other, they give them the options. And so they're doing a lot of education on that now. And some people are not taking Medicare Advantage anymore because it pays such a low amount for reimbursement. The hospital just can't survive on that. So nationally, since 2005, 192 rural hospitals in the US have closed. And just as an aside, in Texas, I was looking at some stats a while back. In the 70s or so, there were over 300 rural hospitals in Texas, and we're down to like 160 some. Nationally, we've lost 104 have closed completely, 88 have converted, and they don't provide inpatient anymore. 600 in the U.S. were at recent risk of closure due to financial pressures. And since 2023, 18 hospitals around the country have converted to rural emergency hospitals. And that number might have ticked up a little bit since I did these slides. In Texas, since 2020, we've had 26 permanent or temporary closures. They tend to be permanent. We just lost St. Mark's and LaGrange. They had just converted to a rural emergency hospital, and then a month later, they were closed permanently, which was really, really hard to see. And so that's the one closure that we've had in Texas since 2020. There are 76 currently at risk of closure and 12 are at immediate risk of closure. And so COVID money helped kind of shore things up for a little while, but that money is going away now. And so, that's sort of taken the finger out of the dike, and now they're getting hit again. They don't have that cushion that COVID funds provided for them. So that's been a real challenge for our rural hospitals. So we want you to understand the importance of rural hospitals on your community when you're doing community planning or economic development. Think about supporting your rural hospitals, think about them in that plan. From a judicial standpoint, I know that folks in a mental health crisis get taken to an emergency room quite often. It's not the ideal place to take somebody with a mental health crisis because the folks there aren't necessarily trained for that, but it does happen. But if you lose your rural hospital, you're driving somebody with a mental health crisis, maybe an hour or more away. And that's a real a struggle as well. where are you going to take this individual? So there are some of our hospitals that are really working on collaborative partnerships, but they tend to be in areas where there's a little bit more resources. If you're way out in West Texas and there's not another town for 35 miles and you lose your rural hospital, you're going to drive that much farther. East Texas, I can hit a few towns in between hospitals, but in the West Texas and the Panhandle, there isn't often anything between those towns at all. So that's the importance of rural hospital closures. And we want to talk a little bit about what we do as an agency in terms of how we support a little more specifically. We provide a grant every year called the SHIP grant, and any hospital that's eligible gets it. It's not competitive. Provides up to $10,000 to $12,000 in funds to help them with their quality improvement efforts and payment systems. I won't go into all the details on that. So hardware, software related trainings. SIP is a program that I work on, which is the capital improvement program. It is a competitive grant. It provides up to $75,000 in funds for hospitals to make capital improvements. So maybe a new roof or a new mammography equipment, a new MRI, remodeling the kitchen or dining room, patient rooms, anything that is not going to be funded in some other way. This is very hard. These are very difficult funds for rural hospitals to come by. There's not hardly any grants out there for capital improvement. So this is really competitive. Our hospitals are really, really wanting this. So this year we have up to $100,000. We have some money that was left from COVID because we had a year where we didn't do this grant. So we have some rollover funds. And we normally fund about 25 hospitals. This year, we're hoping to fund about 35 to 40. We did the same last year. So we're really thrilled to be able to do that because we know how much they need this. Rural health clinic support. This has been a new venture for us in the last few years. We have an individual, Albert Ruiz, who is kind of leading this, and we are collecting like little cohort groups of rural health clinics who are providing us with information on what kind of support that they're needing. We're doing workshops and trainings for them, just like we do for our rural hospitals. We have come up with a toolkit for them. So there's no federal office for rural health clinics. There's no kind of overarching governing body. And so trying to find out what they need to do to stay compliant, how you open a rural health clinic. That information is usually gathered by, working with a for-profit company. Now, we have put together a toolkit that they can access online at one of our partner websites where they can find everything that they need to open a rural health clinic or stay in compliance with regulations. Now, sometimes that may still mean hiring an outside person, but you can kind of minimize your cost and the work that you need to do by using the toolkit. So that's been really popular because the rural health clinics have not had a lot of support and love out there in the communities. Some rural health clinics are tied to hospital systems. Some are standalone independent rural health clinics or maybe owned by a for-profit group. So we have a number of workforce retention funds. We have the St. David's Foundation, which is kind of more towards this area here. We have the Temple Foundation in East Texas. They serve 26 counties, and this is for student loan reimbursement or retention of current employees. So, and we also have a new program, the Nurse Scholarship. It's not released yet, but it was funded in the last legislative session. So we're excited to be rolling that out. We have board education. Rural boards are a little bit different than boards in urban areas, so they need a little specialized training. Some of them have never been on a board before, or they don't understand the hospital language or how the hospitals are funded, or even basics as to what their role is as a board member and what is appropriate things to be working on and not working on. You're not micromanaging staff every day. You're there to oversee the hospital. Excuse me. Workforce retention. We have a group called 3R Net that we work with. That's a nonprofit that is actually a website where people who are searching for employment in rural facilities or hospital or medical facility that's looking for someone who wants to work in rural. So it's kind of their meetup site. So they can look at each other's profiles and decide whether or not somebody wants to apply for a job or whether they want to reach out to somebody to hire them. So this is actually funded through HRSA. It is a private nonprofit though. And so we have the 3R Net Texas representative here in our office, and we're also working on some other areas in terms of workforce recruitment. It's a challenge for our rural communities to get somebody to move out to rural, especially a professional, a doctor. You know, some folks are homegrown, nurses, lab techs, things like that, or some people just want to be in rural, and so they come out there and work. But it is a bit of a challenge to get somebody to move their whole family if they've never worked in rural before. We do have some incentives. There are some programs around the state with rural healthcare programs from universities. UT Tyler has one, Texas Tech has one, and so those folks get placed in rural to work through their residencies. Our rural community paramedicine, that's a pilot program we're doing in the Panhandle, and that is to reduce readmissions. So if you have someone with a chronic illness that keeps coming back into your hospital, you eventually are going to get dinged by Medicare, Medicaid on the costs. And so the goal is for them to get their health really well stabilized so they're not continuing to come back in. And so we've been training EMS to go out, and they do visits after someone's been released to the hospital, do blood pressure checks, diabetes, kind of check the home to see if there's any impediments to their movement. Um, are there issues with food or something falling apart that's affecting their health, within the household? And that also gives them some social contact as well, which is really important. People can get very isolated in rural areas. Our broadband initiative, that is new. So we've selected 8 hospitals where they're getting quite a lot of funds to really get their broadband boosted and to really bring that into the hospital so they can have better telehealth services or telepsych services. They can do remote patient monitoring. So someone might be wearing a device that is recorded into a database, and the doctor can look at that and go, oh, I see you had a lot of fun on March 17th on St. Patrick's Day. I can see by your heart monitor something's going on, or your diabetes. Your numbers are not looking good. So that can really help with, they can contact that person and say, hey, what's going on? What can we do for you? I can see things aren't looking good. So let's go ahead and kind of go back to the healthcare practices that we were doing prior to this. So we're excited about that. The rest of the hospitals in the state are all getting $100,000. Those are all the rural hospitals, of course, and that's going to help them boost their broadband. Our data support project, that is a really cool project that was developed. It's pretty extensive. All our rural critical access hospitals have access to a dashboard where they can look at their service area. If they have, say they have a particular service like MRI, and for some reason they're not getting referrals from the local doctors, they're getting referred out into other areas, other communities. Where are they going, and how do you capture that market back? Also, what is the cost that other people around you are charging, and are your costs in line with that? We had one hospital that just for an intravenous jab, the needle was charging $8, where somebody else down the road's charging $40. And so $8 is not going to fund, it's not going to cover your cost. So some hospitals haven't upped to their, what they call their charge master, which is basically their list of medical codes and the charges that go with them. They haven't updated those in 10 years. And so they're really far behind in their charges. And so they're losing money on these services. So we can help them analyze that data and use it in lots of different ways. Excuse me, it's a pretty exciting project, actually. How am I doing on time, Molly?
We still have half of our time left, Trish, so keep going.
Oh, okay, great.
Yes, ma'am.
Next is our Texas Farmers Mental Health and Suicide Prevention Program. So this is a program that I manage. We have 2 partners that do a lot of the work for this program. It's taken on more of a life in TDA than we had ever expected it to, but we're really pleased about that. It's obviously a great place for a program like this. So the Mental Health and Suicide Prevention Program was initially funded by the USDA for a year. That was about 3 years ago. And through those funds, we were able to develop the AgriStress Helpline for Texas. The AgriStress Helpline is a line and phone number that is owned by the AgriSafe Network. They have this line in 9 other states right now, and it's a really incredible service. It is 24/7 phone or text. So if someone who works in agriculture is having a crisis, excuse me, if they're having a mental health crisis or relationship issues, or they don't have money to buy seed or hay for the season, they can call the helpline. It is a crisis line first and a resource line second, but we get calls for all of those things. We have had calls with suicidal ideation. As an occupation, along with forestry and fishing, agriculture has the fourth highest suicide rate. Actually, that's as an industry. As an occupation, farming has the second highest suicide rate. So you have to distinguish between occupation and industry. So they face a lot of things in their daily work that we don't face. They can't control weather patterns. So we had wildfires. We just had flooding. I'm in the middle right now of getting helpline printed materials out to the 68 hospitals that are in the 88 rural counties that were declared disaster areas by the governor recently. So we partner in this grant with the AgriSafe Network. As I mentioned, they launched and developed the helpline number, and also another training we'll talk about that the call center staff take, and we've also offered to mental health professionals. The other issues that folks face are legacy issues. So if you have a farm or a ranch that's been in your family for 100 years, you don't want that failing on your watch. That's a lot of pressure for folks. And so a lot of people think that, well, the insurance will pay out if I'm not here any longer, but that is not always the case. There are clauses in insurance policies that will state, you have to have this policy for at least 2 years. And, it's just not, it's not the choice we want them to make. We want to be able to be there and help them and provide supportive services to them. If somebody does call the helpline in mental health crisis, they are offered a follow-up call within 24 hours, make sure they're doing okay. They can refer them to folks in their area that maybe provide some counseling. Because of confidentiality, obviously, it's really nice to have a line that you can call in your truck and nobody's around and talk with you. Most folks who work in a rural area, there's not mental health available. 75% of the 406 mental health professional shortage designation area are in rural areas. So there's just not going to be a lot in a rural area. And everybody in town knows your truck, and the last thing you're probably going to do is to park out in front of a mental health counselor. And so definitely, we love the fact that the helpline is confidential in that respect. Our other partner is the UT Tyler Southwest Center for Agricultural Health Injury Prevention and Education. We call it SWAG for short. And they actually have done our mental health public awareness campaign. They create all their social media images, all their giveaways. They go to events. Right now, we have a little project with them to reach out to the youth through 4-H and FFA, going to conferences, ag teachers conferences, to spread the word. And really, our goal is to really start changing that culture of our tagline, "It's okay to ask for help." So a lot of the youth, unfortunately, are a little more familiar and comfortable with addressing the issues of mental health because everything that they have had to face in the schools and in their lives. So, but there are still some, pockets of resistance, of course. And the culture is, you pull yourself up by your bootstraps, you don't ask for help. And so we really want to start kind of changing that message that it is a strength to reach out and ask for help. Everybody needs help. If you break a leg, you're going to go to the doctor. If you're facing a lot of crisis in your life, that's going to be really wearing on your mental health. So we want folks to be able to feel comfortable reaching out. If y'all want to see a really amusing campaign that's not ours, but I wish we had, it's called mantherapy.org. It's really funny. And it addresses men going to mental health counselors. It's been so popular that there's actually a sister program in Australia now, and there are other people that are starting to really catch on to it. It's a funny, very series of videos on a really serious topic. So humor is a great way to get folks to pay attention. This is part of our public awareness campaign. So we have a lot of diverse images. Along with this set of images, we have another one geared towards youth and another a little bit more faith-based oriented. We've done radio and video PSAs. Our commissioner has recorded some things and put them out there. Several organizations post these things on social media for us. And each image that we have on social media has a little tagline, a paragraph that goes with it. So Facebook, Instagram, well, you can see the slide is a little old. It says Twitter, it's now X. And our materials are also in English and Spanish. And in addition to farming and ranching, we also reach out to forestry and commercial fishing. So we do actually have one of our flyers is translated into Vietnamese. So we have a pretty strong relationship with some of the coastal groups and have done some work out there. And so they actually had a person in the community that helped us put this together and make sure that the translation for everybody was correct. We also have a mental health wellness kit that has the mental health first aid training. We've provided that to county extension agencies, our field reps, and livestock pen staff. And we're hoping to move forward with further training on mental health. Something called Question, Persuade, and Respond, QPR. And this one, that is a national model. With this particular one that we're using, they have added a for farm families component to it. So it's agriculturally based on how you talk with somebody who's having a mental health crisis in agriculture. So for year 3, we have our 2 new campaigns. One is our youth-based campaign, which I love these images. One of our folks, a child, saw our original images and said, well, I don't want to pick up a brochure with a picture of a sad person's face on it. So we created these new ones with the animals. They're a little more humorous, a little lighter. I'm happy to say we have a whole group of tote bags for farmers markets coming where we're using these images on the tote bags. We have all kinds of giveaways, but I'm particularly thrilled about these because I think they're really fun and they're catchy. And then ones that are maybe a little bit more reverent, a little more faith-based, where we're using silhouettes and trying to really send a positive message out there to, be a light in the darkness. You're not alone. Reach out for help. So we are trying to do some work within some of the faith communities. You really have to have a person of trust to introduce you into those communities. So we have some connections for that. And hopefully moving forward with year 3, we'll be able to hopefully train some of our clergy on the QPR for farm families. So when somebody does approach them in their church that is struggling, because it is often the first place they may go, that they will have an idea of how to address them. Some people have the natural ability to talk with somebody. Some people are uncomfortable talking about mental health. And so we want to give them the tools that they need. So this is our helpline. This was our main campaign here. This is the number. It's on all our brochures, all our materials. We distribute in all kinds of ways. It's gone to the USDA farm service agencies. There's 173 offices in Texas, our county extension agencies, our rural hospitals and health clinics. I've sent things with county commissioners when we had the flood or the wildfires. There were 12 counties affected. So materials went out to all the county commissioners, extension agents, hospitals, different folks there. We're doing the same for those flood counties also. So it is 24/7 and it is staffed by people who are credentialed professionals trained to respond appropriately to the agricultural community. We have a curriculum called Farm Response, which I'll talk about in a minute, that was developed by experts in the mental health field. It's a 3.5-hour curriculum. So the call center staff also receive up to 300 hours of training, or no less than 300 hours training before they ever get on a phone. The nonprofit that provides this service, they provide crisis line services for a number of different helplines around the country. They are accredited by the American Association of Suicidology, so they can de-escalate a call, talk a person through the crisis that they're having. And they also are accredited by the information and AIRS. It's the American Institute, I think, of Information and Referral Systems. So the 211s that you hear about, those are all going to be probably accredited through AIRS. There are certain standards that you have to follow if you have that accreditation, and the number of hours of training and the type of training is a part of that. We do know that, pretty sure that we are the only helpline for agriculture across the country that answers the phone right away with somebody, by somebody who is um, well versed in agricultural stresses. Now, if somebody is calling and they're not in agriculture, they're still going to work with them. That's part of their standards of work and professionalism. They will talk with them. If they're having a crisis, they can de-escalate them, and then they can refer them on to the appropriate mental health service, maybe in their community, or maybe if it's a specific issue and there's a helpline for that issue, they'll refer them over appropriately for that. So calls, of course, are triaged for the type of call it is. If it's a crisis call, you know, they're all going to get answered. So anybody can call the line. So a little bit about farm response. So farm response is 3.5 hours long. It provides somebody answering the phone with cultural competency in agricultural stresses like land ownership and legacy, the weather issues, all those things that we talked about. We have been able to make this available at no charge. We have now released up to 450 free codes. So a licensed mental health professional in Texas can take this course. The first time we did it, we released the 250 and it kind of broke the system because everybody was pretty excited about it. And we only had 250 codes. We got almost 2,000 responses and set up 600 and some codes. And then we did train 271 licensed mental health professionals in Texas. The Texas Behavioral Health Executive Council, which is the overarching body of 4 different licensing bodies, actually has been gracious enough to partner with us, and they have a listserv of 70,000 people. So it went to 70,000 people. And we did it again recently for 200 codes, and we're not going to have any problem using up those codes as well. So by the time those are finished, we'll have almost 500 people in Texas trained in farm response. They get an electronic badge certification. But the other states, the other 9 states that have the helpline also have the opportunity to take farm response, and they do. So it's been pretty popular. And it's a very specific thing talking to somebody in agriculture. So the legislature did fund us for 2 years in the last session, so 500,000 a year. So we would have received $1 million, and we're hoping then with the next session coming up, they will continue to fund the helpline. I think it's a much needed service, and it's going to take a while though to change that culture. And there are helplines around the country where ours is just a little unique in how it's answered by somebody right away that's culturally competent. They're not transferred to another helpline somewhere else, or so we're proud of the fact that we are answer those calls in less than 30 seconds and can offer some follow-up calls as well. And with this farm response training, all the folks that have been trained in it will now be on a provider database that they have the option to be on. So if somebody's looking for an individual who is a licensed counselor and they want someone that can understand the agricultural community, they can look on that database and find that. And then our call center staff use that to refer somebody if there's somebody that they want to find to continue getting some extra counseling. So these are rural health resources. You can find lots of data on rural health. We use these for lots of different things, grants, presentations. So you can find out, what the health disparities are, what are the health issues in certain areas. I will say around the country in rural, it is going to be COPD, heart disease, smoking, obesity, type 2 diabetes. You're going to see similar issues all around the country in rural areas. So these are just some other ones, and I believe, Molly, you'll be able to send the slide presentation out to folks.
Yes, I will. And for folks who are still with us, I dropped it into the chat just now.
Great, thank you. So these are our regions here and our folks that work those regions. So we're excited. We have a really good team, like I said, a team of 9, and we all love what we do. And we're all champions for our rural hospitals, and we're constantly thinking of new and creative ways to help them and to get them, you know, help them with their bottom line so they can stay open. So if anybody has any ideas, let me know. And that concludes my slide presentation.
Wow. Trish, thank you so much. And for our collaborative council members, I think, yeah, we do. We have several minutes left over for question and answer. And so if y'all don't mind putting your questions into the chat box, I'll take a look at them and ask Trish. But Trish, I have some questions.
Sure.
If you don't mind. You
No,
had
no, no. I'll answer if I can.
Yeah, you had talked about rural hospitals converting to rural emergency hospitals. What does that mean?
So that means you have a small critical access hospital that has a low patient volume. And by that, I mean how many heads and beds? Like how many beds do you usually have in patients in? Maybe one or two. You might have a larger hospital that they have 15 inpatient. It's their inpatient volume is what they look at. So a small critical access hospital with very low inpatient volume can take the opportunity to convert to a model of hospital called a rural emergency hospital. So you keep the emergency room. If you have imaging and blood draws, lab work, things like that that you have always done, you can continue to do those things as well. You just don't have that overnight stay. Now, caveat is maybe you have somebody in an emergency room and you're needing to transfer them to another hospital. You stabilize them and you're going to transfer them, but the bed isn't ready yet. They can stay there for up to 2 or 3 days and then they transfer out, but they can't stay any longer than that. They have to
Okay.
transfer out. So it's not a long-term stay like, your mom has a health issue and she's in the hospital for 2 weeks. You can't do that.
Okay. So yeah, those long-term conditions we're thinking of like care for cancer or maybe a complicated
Correct.
pregnancy or cardiac. Wow. Okay. Well,
Right.
thank you
Right.
for helping me with that. Where can we find links to the SHIP and the SIP grants?
So those will be on our website, which is within the Texas Department of Agriculture website. And their criteria for those, they have to be in a rural designated area. Sometimes size of the hospital makes a difference. The eligibility categories are different. SHIP is a federal grant and SIP is actually a state grant funded through the tobacco funds.
Okay. That's a good designation for us to know. Thank you. The Rural Community Paramedicine Program. Can you tell us more about what rural or just community paramedics are?
So hospitals sometimes have their own emergency services, or the hospital district has the emergency services, or it may be a private company that has an emergency services. Your ambulances, EMTs that are going out. So what we did was we worked with 4 different emergency services. I think 3 are private and 1 is connected to a hospital in the Panhandle area, and we gave them specialized training on going out and doing work with patients in their homes. So the hospital will call them and say, "Hey, so and so has been released, and would you go and check on them? In a week or so." And they are fitted with they actually get a vehicle through this program. Through one of the TDA programs, they're given a vehicle. It's sort of like a Tahoe or a larger SUV, and they can outfit it with all kinds of medical supplies. And they can go out and visit that individual. If it's somebody with diabetes, they'll check their blood sugars and be checking blood pressure and looking at kind of their environment, because environment, the social determinants of health and environment are really crucial to somebody's overall health as well. So they may refer them to community services, maybe a food bank or um, some other, maybe housing or clothing or something like that. So it's designed to help reduce those hospital admissions, keep that person from coming back. Loneliness is a big problem for a lot of older people in the rural communities. It can be very isolating, and especially if you don't have a vehicle. I was at a conference recently, and there was somebody who was telling a story about a woman that she kept coming in because her blood pressure was so high. Turned out that from a nutrition standpoint, she couldn't go out and get her own food, and the only place that would deliver was a Chinese restaurant, and that's what she ate all the time. So it's looking at a person like that. It's like, what can we do to help that individual? They function a little bit like a community health worker. And so we had great success with the hospital EMS in reducing those admissions down to like 3 or 4%.
Oh my goodness.
A much higher range previous to that. So it's a pilot project. We work with Department of Health and Human Services on that grant, and I think we're expanding to maybe a couple more areas.
Okay, yeah, I think many of our jurisdictions would be interested in that. So when that becomes available, do
Yeah.
bring that with us.
Yes, I will. If it does, I'll let you know. Yeah. Yeah, we'd love to see something like this, statewide. We'd love to see hospitals hire community health workers. There is some plan, I think, for those to be, you can get reimbursed somewhat through Center for Medicare and Medicaid Services if you're billing for a community health worker, but you also, you have to have sustainable funding for that individual.
And now we have some questions from our members. Is the AgriStress helpline just for mental health support, or would it also provide support with financial assistance and other
It does
needs?
provide support for financial assistance. So if somebody, say, doesn't have the money to buy seed for that season, they can contact the helpline, and the helpline will direct them to resources for financial assistance. They have about 70 different resources that they can refer folks to for various things.
And you had mentioned that some hospitals were getting dinged or penalized on CMS patients who are presenting too frequently. How does that relate to the mental health population, some of whom are also likely to present frequently?
It's really probably more an issue of the chronic health issues, not so much the mental health issues. Because with those readmissions, they're coming in for a recurring health issue, not usually mental health. Mental health is going to be probably emergency room. They're not going to be coming back all the time for mental health unless, they're in a serious crisis all the time, but it's more about those chronic health conditions.
And did you know if the St. David's Foundation New Nurse Scholarship could be used to expand the mental health workforce, I guess like psychiatric nurses in rural communities?
That's a good. So those are two separate things. St. David's is actually the foundation here in the Austin area that serves a specific geographic area for physicians. The nurse scholarship is separate. That was a recently funded program, not yet launched. As far as mental health, it may be, but I don't know all the criteria. We haven't launched the program yet.
Okay.
But it would be great if it could.
Yeah. Do you know of any resources out there to expand the mental health workforce?
I believe on the SAMHSA website, there may be some grants available.
I think so. And I do know I'll have to find the bill number and the website information, but there is some tuition reimbursement or student loan reimbursement available for certain categories of qualified mental health professionals that should have just started on September 1st.
Okay,
So
great.
that's out there as well.
Sure. And also the HRSA website too, Health Resources Services Administration.
Okay. And one more thing, where could we find the farm response course?
On the AgriSafe Network website.
Okay, thank you.
And
I can got that. And you also mentioned
just FYI, they are based in Louisiana, but they are a nationwide nonprofit. They do a lot of advocacy for the helpline right now, and they actually have helped put some language into the Farm Bill. And so we're excited about that. So we really hope to see the AgriStress helpline become a national model for a helpline.
Yeah, that'd be great.
So far, we're in 10 states. We've got, I think, Arizona thinking about it right now too. So the challenge is Texas is so large. I mean, it's in Connecticut, and I could probably walk materials across Connecticut. But in Texas, I can't do that. So I rely on strategic partners to help spread the word.
Yeah, there are farms that are larger than some of those states up north.
Yes, and as a comparison, Connecticut has 5,000 agricultural productions, and we have 250,000 thereabouts, give or take.
We have another question. You mentioned the role that rural hospitals can play in supporting people who are experiencing a mental health crisis. Do you have any recommendations for expanding the capacity of rural hospitals to respond to people who are experiencing a mental health crisis?
I would say more training for because they're coming in through the emergency room, and it's very stressful for the emergency room staff. Now, the HHSC's rural mental health office has been conducting some focus groups with some of our small rural communities, and including the hospitals in those, and they've actually gone out and talked to the emergency room. So they are getting some feedback on what they're experiencing and what they need. Training, definitely, they're not trained for mental health, and it's not the best, most ideal place to take somebody in a mental health crisis, but oftentimes it's the only option.
Yeah, we hear that again and again. Are you getting any feedback from your rural emergency rooms on the presentation of people who meet criteria for admission to a mental health facility?
We get anecdotal information from them, just on how stressful it is. But there's a lot of drug related mental health episodes. That's kind of a big one, and that is, either someone who's an addict. They may be self-medicating. There's a lot of meth out in East Texas.
Mhm.
Some areas they're more opioids, some areas are more meth. So, depression. I don't know all the diagnoses. I don't know what the most presenting mental health illness is, but substance abuse is pretty high up there on the list.
Yes. Yeah, we find that substance use and mental health sometimes go hand in hand. So,
Yes, oftentimes.
okay.